My name's Margaret Armstrong and I'm the Falls Prevention Coordinator for Northern Sydney LHD. My work covers hospital and community, so I'm delighted to be here for this session. So I'm welcoming you here to the session and also welcome to our online people. Okay, our first presenter, I need to take my glasses off for this. Our first presenter is Glade Vasil, Team Leader, West Lakes Community Rehabilitation. And Glade is going to be speaking about reducing gaps, implementing best practice falls prevention in community rehabilitation. Welcome.
Okay. It's nice to be with you all today. It's likely that many of us work in a range of community settings with various resources and constraints. And I'm really passionate about making the most of available resources. So today I'll be talking about falls prevention from that perspective, optimising available resources. Oh, good. Teamwork, better? Thank you. Applying knowledge and skills into practice, quality improvement and behaviour change. So as mentioned, my name's Glade and I'm an occupational therapist and team leader for West Lakes Community Rehabilitation Team, located at Toronto, New South Wales, the land of the Awabakal people. I put my contact details up. If anything here sparks your interest, please feel free to get in touch, or you can Google my team. So our small team provides outpatient, outpatient, home-based and community rehabilitation. So we're not a falls-specific service. And our staffing profile's small, it's 4.5 FTE. We work with community-dwelling adults in an age and diagnosis diverse setting with a focus on physical rehabilitation. Our populations include people with subacute illness, acquired brain injury, neurodegenerative conditions, and then a large group of people that present with multi-morbidity and falls. We aim to provide patient-centred, goal-focused rehabilitation. And our patients self-identify goals for therapy, so they can be really wide-ranging. In our experience, the majority include some form of priority around balance, strength, falls reduction and mobility. So we see people who live at home and want to stay active in the community. So that brings us to falls. So as a team, we've been learning about falls and falls prevention for many years, and it's really because it's a common denominator across all of our populations. So optimising skills in this area, it's an efficiency strategy for our team. It's useful across all our patient groups. So I want to pause here and say thank you to all the falls prevention researchers and gurus, many of whom have been here today. It's really amazing the access we have to high-quality falls prevention research and low-cost education around falls prevention. And all of this access helps us to apply that research into practice. So for the next 10 minutes, that's what I'm going to share, ideas about implementing falls prevention research into clinical practice using your available resources, teamwork and quality improvement. So back in 2020, we developed a flowchart of our existing falls program, and it was the result of many previous quality improvement cycles. I appreciate it's way too jam-packed for people to decipher, but what I'm going to do is simplify the content and talk about the things about our 2020 program that we were really most proud of. We offer a multifactorial falls program in a multidisciplinary rehabilitation team environment. Our intake assessment includes a patient-centred interview, an investigation of people's social situations, falls history, an environmental assessment, it's often done at home, a functional mobility review, vision, medication, continence, and an exploration of people's physical activity history. So the intake assessment is an empathetic listening opportunity, and it's a real chance to build a connection with the patient. We're trying to get a sense of the physical, psychological, social and environmental risk factors for falls. So within our resource, we have limited capacity to address these falls risks, but we do touch on them. So in terms of medication, if we identify that people have polypharmacy, we might suggest that they have a GP or pharmacist review. In terms of vision, we do ask people about their vision. If they talk to us about cataract surgery, we're encouraging it. We're encouraging them to connect with their optometrists and eye specialists. We're investigating glasses, and if we identify a risk there, we're encouraging people to review that. And last but not least is continence. We assess and refer to continence nurses, and we really can't underestimate the impact of optimising someone's continence management on quality of life, reducing falls risk, and a really big one is confidence to access the community. So without good continence management, people just stop going out. So we have a flexible model of care for our rehab program, which includes falls. We see people as outpatients, provide home-based therapy, and do telehealth. We work really hard to include carers, families, and support services, aged care and NDIS. We do what we call a double date, which is if we identify frailty or falls risk in a carer, we also offer them attendance at our program. And this is an adherence or behaviour change strategy for some people, so make it fun. We do education and planning with carers and service providers because we're wanting to explore all options to reduce someone's falls risk, including accessing funding for equipment and home modifications. And really what we want is carers and support services to get on board and be involved so that ideally they can continue to support our patients to exercise at home and in the community when our program finishes. So as a team, we've also learnt a lot about behaviour change strategies, and this is in the hope of being more effective at supporting our patients to make a change, to build a habit around strength, balance and falls prevention. This model's come up a few times today, and basically engaging with the community rehab team presents an opportunity to change behaviour. So some of our favourite behaviour change strategies are goal setting, problem solving, action planning, grading tasks, social support, celebrating success and feedback. Standardised assessments are really useful for program and evaluation, but more importantly, they're useful for patients. So sharing results is a behaviour change strategy. We want to empower our patients to close that link between exercise, feeling better, doing more, reducing falls risk, hopefully improving quality of life and enabling people to have more fun. So we've heard today, exercise only works to prevent falls while you're doing it. So people need to keep challenging their balance and strengthening across a lifespan. So we're really committed to this idea of working hard on effective discharge planning. We investigate physical activity from admission, and what we're doing is exploring motivators and barriers to change. This enables us to look at options for ongoing activity when our programs finish, and then to support transitions to community exercise programs. So practical social supports is a behaviour change strategy. So in our team, we might do a one-off introductory supported attendance at a community exercise program, strength and balance, Tai Chi. And this works really well when people have anxiety, so they're too afraid to go into that new situation. Or we might just be working through logistics, cost, transport, practical supports to attend a program. So our multifactorial program had strengths, and we recognised after attending the 2019 and 2020 Falls Forum that it still had some gaps. And we wanted to keep working to close those gaps and to make the most of our available resource. So we did an evidence review. We thought about Professor Lord's gold bars, and we reviewed articles that were most relevant to our clinical setting and available resources. So we learnt more about physical activity and falls prevention, looked at systematic reviews, and we thought particularly about this idea of challenge and dose, and considered that our patients might not be getting enough, and that perhaps we lacked not only the confidence and skills in prescribing exercises, but actually getting people to do them. We looked at evidence around environmental assessments, modifications and equipment, and we questioned if enough referrals were getting through to our occupational therapists and if we were covering all of the options for falls prevention. And perhaps really considered for the first time podiatry, foot pain, foot care and the relationship to falls, which our interventions in this area had been pretty sort of ad hoc up until this point. We brainstormed our issues and gaps, and we developed a driver diagram. So our multidisciplinary team still had plenty to work on. We set ourselves the goal of reducing gaps in our falls program by 50% in 12 months. So the WCRT stands for West Lakes Community Rehab Team. So a driver diagram helps us not only to identify gaps, it provides us with an action plan. So it generates change ideas, and it's a behaviour change technique, supporting us to move forward with practice change. Staff identified the following primary drivers: increasing their knowledge of skills, and that desire to have more consistency in those knowledge and skills across our whole team; exercise, challenge and dose; home hazards, environmental modifications, and podiatry. COVID resulted in our 12-month goal being given a generous stretch to a 3-year plan, and what surprised us most was that when we sat down to reevaluate our progress, we'd made some. So pre and post surveys showed that our knowledge and skills had increased, not only through our original evidence review, but also through online learning opportunities. And these were some that our team completed. We understood more about dose and working in the challenging zone. And while we can't yet say with confidence that we've got to that magic 3 hours at the right dose, we're definitely moving towards it. We've got a small team, and at times we need to cover our physiotherapist sick leave and annual leave, and our multidisciplinary learnings have enabled us to do that with more confidence. Audits of our medical records showed that we referred more people to occupational therapy, which resulted in more access to modifications and equipment, and our occupational therapists completed more falls interventions, including supporting adherence to strength and balance programs. We ask people now about foot pain and podiatry. We know how to refer on to podiatry in our own health system, and also to link people with private providers. And as a team, we've got really good at discussing footwear and using behaviour change strategies to support our patients to actually change their shoes. So we met our goal of reducing gaps in our falls program by 50%. And we recognise that the more skills and knowledge we have, the more choice and control we can actually give to our patients about reducing their own falls risks. So in conclusion, I really just invite you to think about closing gaps in your own program, to have a go at optimising your available resources, teamwork, applying knowledge and skills into practice, quality improvement and behaviour change. There's really a huge amount of work to do in this area, and it's awesome that we can all share the load to work together to prevent falls. Thanks for listening. So because, so how long?
How long does the program go for? What is your duration?
Yeah, so because we're not a falls-specific service, we're a community rehab team. There's other alternative programs like Stepping On and things that are run out of our building, but it's variable because of those diagnostic groups. So for a classic person that prevents with multimorbidity, frailty and falls, it's around the 12-week mark. Obviously, when we're seeing people with motor neuron disease who have different issues around their falls risks, that's a much longer. So it comes under who funds the program. Yeah, so we're it's generic funding where we sit within the rehab model of care.
Of health, New South Wales.
New South Wales Health.
Right.
Yeah.
Okay. Right. So, and do you have to do your own admin, or like to bring the patients on, or is
we
that
have
sort of
in
done
Hunter? We have a generic referral and information centre that sort of gets the referrals to us. But yes, we don't have an admin assistant. Yep, so waiting times vary, and we use a clinical priority tool. So unfortunately, an acute stroke perhaps might trump a frail faller in terms of that clinical priority.
And you mentioned the COPM. I'm just wondering, do you do that for every client? Do your clinicians find that feasible?
Yeah, we've written a whole paper on it. You can review it. But I guess the thing, it's complex, and it's taken years of quality improvement to get us to that point. The beauty of that tool and other patient-centred measures is that capacity it has to sit with connection with the patient, to really understand what's important to them, and work first on those areas to build trust and confidence, and then perhaps move on to some other things that are a risk as that grows with the patient. Thank you.
Thank Blade for the presentation. Okay. Our next speaker, we have two speakers actually. We have Deborah Moore, who you've seen earlier today from Novacare, and Dr. John Ward from the Hunter Ageing Alliance, and they're going to speak to about active, stronger, better, serving Newcastle and Lake Macquarie into age-friendly cities. Welcome.
Thank you. Well, I'm going to, how much time have we got? 12 minutes. 12 minutes, is it? I'm only going to speak for 5 minutes because what Deb's got to say is much more interesting than what I've got to say. So this is just the background to how we came to Active Stronger Better. So about 3 years ago, as I said, I'm addicted to alliances and networks, and a group of us who'd been around aged care for a long time in the Hunter got together, and we all came to the same conclusion that the government wasn't going to do much for older people unless we got in and started to help. So we formed the Hunter Ageing Alliance, and we have a leadership group of about a dozen and a membership of a couple of hundred and about 30 corporate bodies who are members. And we set ourselves 8 strategies that you can see on the board that I can't see because of blinding light in the road. And about 6 of these we knew what we were doing, and 2 we didn't have a clue. Now, the 2 where we didn't have a clue were what to do about social isolation and vulnerability of older people, particularly in extreme heat days and so on, and we still haven't really made much headway. The other one where we didn't have a clue is about housing, and that's where we have made some headway. But one of the things we obviously did know what we're doing, and we've done some work on every one of these. We've actually about to start a face-to-face portal in Belmont, so that people can come and get information about ageing, not just about my aged care, but about all the other things they need to know, because older people struggle with my aged care, as you can imagine. And we hope once that's up and running and staffed by volunteers that we'll get one going in Newcastle. The second one, environment, we're working with the council, and that's good. Elder abuse, we'd actually done quite a lot of work in the Hunter on that, so let's just continue what we've done in the past. Later life support and end-of-life care were pretty familiar to us. So healthcare, we knew what we were doing. Of course, we knew what we wanted, and we set ourselves 2 main goals at the start. One was to design a service for the assessment and management of dementia in the Hunter, not a Rolls-Royce service, a Mazda service for everyone. Now, we thought if we just designed this and took it to the local health district and to the PHN, they'd say, oh, that's wonderful, let's do it. We did that, and they sent us on their way with a flea in our ear. So we've gone back to grassroots, and we're working with the people at the bottom. We'll take it up from the bottom up. The second one was one where I ran into Deb about 3 years ago when we were lamenting that we'd lost all the wonderful exercise programs we used to have in the Hunter. And these were Heart Moves and Active Over 50s. Now, Heart Moves, the funding was withdrawn by the cardiac rehab, and Active Over 50s, which was funded by the local health district, was withdrawn when certain people lost their influence. So we've worked hard over the last 3 years, and we have a large consortium that involves the university, chronic disease, COTA, Fitness Australia, fitness leaders, Uncle Tom Cobley Law, and we gained money from the New South Wales Health Ministry, and that's what Deb will talk about today, the Active Stronger Better. Now, so let me just finish up by talking a little bit about housing, because this has become a really critical issue, as you can imagine, and one that the governments really are walking away from. And any of you who saw Q&A last week will see what a shambles it is. So we thought originally we were looking at the range of options that there were for older people in housing and accommodation. If you have to leave your own home, you basically either go to an aged care facility or to a retirement village on the outskirts of nowhere, and you might as well you lose contact with your social network, your doctor, and everything else. But then we realised, of course, that the most rapidly growing group of of homeless people were older women. So we clearly had to do something about that. And then we realised the size of the problem and the number of reports, the number of research things that have been done, And if you had $1 for everyone, you could house everyone in Australia 7 times over, but nothing actually gets done. So we realised that this is only going to work if private investment and government work together. So at the moment, our major work is in what we call the meanwhile use of vacant buildings. And so we've got a couple of vacant buildings that we're working on at the moment. That's the info, yeah. Where we rehabilitate the building at no cost to the owner. If they give it to us for 3 to 5 years, then we hand it over to a community housing provider, and they can put in women who need accommodation, not immediate accommodation, they've gone through that period, but after the first month when everything's been settled down, they can come here for sort of 6 to 9 months. So that's where the major activity is at the moment, but there's a lot of other stuff going on, granny flats and home share and tiny homes and God knows what. So that's what the Hunter Ageing Alliance does, and the best bit of it is Active, Stronger, Better.
All right. Thank you. So I wouldn't say it's the best bit, but it's the bit that I'm working on and the bit that I'm very, very excited about. And hopefully one day we'll look back and go, oh, that was the best bit. So the program Active, Stronger, Better has been advocated for by Hunter Ageing Alliance. It's been funded by the Ministry of Health, and it's been delivered by Novacare Community Services in Newcastle. Essentially, Rosanna there on your slide is kind of the epitome of our client group. She's got a walking stick. She's needing the chair for some of her exercise work. She has a big smile on her face because basically that's all they do all session is laugh and have banter and do their workout. But essentially from a more serious perspective, our goals are within Active, Stronger, Better can be summarised by basically trying to improve the access and the opportunities for older people to exercise in the community. We want that exercise to be safe and effective and very relevant. And obviously, I think I mentioned in that last section, there's all of the research and there's all of the beautiful findings and there's this body of work that's been done. But when you sort of bring it down to turning up to Swansea on a Friday afternoon to deliver your exercise session, some of those elements of that research might appear and some might sort of fade away a little bit. But over the long term, if people keep on coming, then those research or that evidence will obviously become apparent within the participants who are coming along. The methodology we're using is to really identify gaps within the local community, find out what's actually happening out there. So I guess what I probably should declare is I'm coming from a fitness professional perspective, not a physio, not an EP, not an OT. I think you guys just do tremendous work. But when you're looking at community venues like church halls, scout halls, gyms, senior halls, pensioner halls, that's where some of these participants like to come. That's where they live. That's where they socialise. So to put an exercise program in that type of facility is actually just perfect common sense. So there are also a lot of other programs delivered by fitness professionals in the region that we're trying to find. Do you run a program for the older adult that kind of fits these safety criteria? Well, let's talk about you. Let's bring you up as an Active, Stronger, Better campaign member. You not necessarily have done any specific training other than your fitness qualifications and furthering your education that we have to do as a fitness professional. But you might be running a program that is just perfect, and so we're going to sort of signpost all of those programs in the region. And then also working on precedents, and John mentioned a couple, Heart Moves, Active Over 50s, and there's others in the community that I'll talk about in a sec. The timeline's about 12 months. We've just extended it a little bit because we're just heading into the flu and COVID seasons again, and so some things might take a little bit longer, whereas older people might be staying home or not coming out because it's a very cold day or they've got the flu or someone else has got the flu. We're hoping within the Active, Stronger, Better model to create novel settings and also use existing settings. And we're looking specifically at acceptability and reach because we already know that exercise works. So we don't really want to go and measure that again because that's been measured in very rigorous ways across the decades and is still being measured in rigorous ways, which is fantastic. But I think for our project, we really are looking to see whether or not this can work out in community. So as John mentioned, we've got a consortium with fabulous membership from all sorts of different areas, academics and researchers and community providers and private providers, etc. We're looking at implementing good exercise habits in participants. We're not necessarily always going to be looking at you need to spend this amount of time doing this many repetitions at this many or this percentage of maximum weight or heart rate, all of those clinical indicators. We just want people to come and get into the good habit of exercising together. So yes, applying the research and the evidence, but with a few little interpersonal and individual variations depending on the centre and the leader and the participants who come along. So talking about the gaps, we've done a little bit of a phone survey of just about everyone that we could find on the fitness industry, whether it's LinkedIn or Google or how many PTs and gyms there are in the region. And there's a lot of people who are not working with older adults, and there's a lot of people who are. So it's just about finding those who are, what are you doing and can we promote you? And those who are not, why not? And would you? So we're sort of working on that. And those are the, I guess, the programs up there are the programs that we've identified in the fitness industry that have got good credibility, good track record of engaging older adults, engaging health professionals to deliver a program that's suitable for and relevant for the participant. Some of the other ones there, I think, are Northern Rivers and also Sutherland Shire. Okay, thank you. We also understand from those programs what's required for scalability, and we're working with that. 12 months-ish, where I won't go into any detail there specifically, but we have achieved quite a lot in the first 6 months. We've still got a lot to do in the next 6 months. And it's not necessarily a research project, so always happy to collaborate and use opportunities that come up that make good sense for people getting into exercise. And that's still what we've got to do. And again, the residential aged care facility work is something that we've sort of done in the past a little bit with Heart Moves, but we're really looking to try and engage residents, staff and families and try and get some good exercise habits that don't necessarily use more health professional time in facility, but bring the fitness professional to the facility. And that's, I guess, just bringing the joy of movement to older Australians, and that's a description of kind of where we feel that the fitness industry can link in with the various groups from an aged care provider perspective. And this is how you might contact us if you've got any further questions. Just very quickly, the subject of the talk was sort of making Newcastle and Lake Macquarie age-friendly cities. Some of the initiatives that the City of Newcastle are incorporating are 30-kilometre speed zones for vulnerable road users and housing cycling without age bikes. And Lake Macquarie City Council too is housing cycling without age bikes and promoting Novacare programs that engage other people in the community to do active things. Any questions? Thank you. Thank you.
Thank you, Deborah and John. They were great. There's so many good things that we're learning here. Our next speaker is an old friend of mine who escaped from Northern Sydney Health Promotion. I'd like to welcome Amanda Bates, who works in health promotion in Illawarra Shoalhaven LHD, and she's also a PhD candidate. And Amanda is going to present further on the talk we heard a bit about this morning, Best at Home, a home-based balance and strength training program to prevent falls. Thanks, Amanda.
Thank you. Thank you. So I'm here today to talk about Best at Home, which is a home-based balance and strength exercise program that we delivered via workshops to prevent falls in older people. So we all know that there's strong evidence that exercise can reduce the risk of falls, but the uptake of evidence-based exercise programs is quite low. Research has shown that home-based exercise programs may be more appealing to older people due to convenience, access and lower cost.
The Otago program is one of these examples that was shown to reduce falls, but is very resource intensive with individual home visits provided to participants. So we looked at using the Otago exercise program and looked at a new delivery method by giving the instruction in group-based sessions, and we titled that Best at Home, standing for Balance, Exercise, Strength Training. So the aim of our study was to determine the effectiveness of Best at Home for preventing falls among community dwelling older people, and the trial protocol was published in the Journal of Physiotherapy. That's an example of our ad and flyer that we used recruiting participants. We had a very broad inclusion criteria for people 65 and over living in the community in the Illawarra and Shoalhaven regions. As mentioned earlier, we didn't talk about falls in the ad. It was mainly about staying strong and active. We had a huge response to that, those advertisements and promotions, and we recruited 617 people into the study. So what did we do? The exercise intervention was delivered via 3 group workshops by physiotherapists at weeks 1, 4 and 12. The workshops were 1 hour in duration with approximately 10 to 12 participants in each of the groups in local community venues such as leagues, clubs and community centres. And the program was tailored to each participant's ability. At each of the sessions, the exercises were reviewed by our physiotherapists, techniques were corrected, exercises were adjusted or progressed according to each participant's level of ability. And participants received an exercise manual and weights to complete the exercises at home. So our intervention group, they received the home-based exercise program to improve balance and strength in the lower body, and this was based on the Otago exercise program. Our control group also had an exercise program, but that was focused on improving upper limb strength, mobility and function. And that was designed by members of our research team. We then asked participants to complete the exercises 3 times per week over a 12-month period. So they're the exercises that you see in the Otago exercise manual. And that's the upper limb exercise program that was given to people. Obviously there were more exercises than those, but you can see the examples given there. They were all done in a seated position, so as not to contaminate the balance effect of the lower limb exercise program. So our primary outcome was rate of falls, which was assessed by monthly calendars over the 12-month period, and we also had a number of secondary outcomes at 3, 6 and 12 months, looking at balance and strength, physical activity, fear of falling and quality of life. And that's an example of the calendars that participants were given and sent back to us on a monthly basis. So the results were published last year in BMC Geriatrics. There's a QR code that I'll put up again just at the end of the presentation if you don't get it now. So what did our participants look like? We had 617 participants with a mean age of 73 years. 64% were female. So obviously we had 36% male, which in terms of what we normally see in our local community exercise programs, a much greater proportion of males enrolled in this. Really similar to normal stats, 27% reported having had a fall in the year prior to joining the study, and 25% rated their fear of falling as moderate or greater. Over the 12-month period, there were 267 falls, with 138 in the intervention group and 129 in the control group. However, there was no between-group difference in the rate of falls. We did see significant improvement in the intervention group for fear of falling at 3, 6 and 12 months and gait speed at 3 months. We did do some exploratory analysis that looked at people who'd reported 2 or more falls in the year prior to joining the study, and we did see greater intervention effects in those, but it wasn't quite enough to reach significance. So we looked at adherence over the 12-month period. From the calendars, people recorded when they did the exercises, as well as any falls on those calendars that they sent back to us. And the intervention group participants completed the exercises just under twice per week. The control group participants slightly more at twice per week. And we also recorded attendance at the sessions that we ran, and you can see that the attendance does drop off slightly as you progress at weeks 1, 4 and then to 12. We asked participants questions on what they thought of the program throughout that 12-month period. At 3 months, 96% felt confident doing the exercises at home. And at 12 months, 93% would recommend the program to others, and 81% intended to continue to do the exercises. The features that people reported most liking were that the exercises could be done anytime, they could be done at home, and they were quite simple to follow. At 12 months, the questionnaire, we asked if participants had any issues or problems completing the exercises on a regular basis, and the most common cited reasons were going away on holiday, injury, lack of motivation, being too busy, family commitments and ill health, which very similar to reasons that are reported in other studies. So I guess it's uncertain why there was no clear impact of this exercise intervention on the rate of falls. We could see that the minimal supervision that people had may have resulted in an insufficient challenge with no formal progression beyond that 3-month mark. And with people performing the exercises less than twice per week, probably the dose wasn't high enough. As I mentioned earlier, we could see their adherence decreased later in the program, which those later sessions were really where the exercises were progressed, where people had learnt the exercises, but they were challenged a little bit more. So some people missed out on receiving that information. We also had a very healthy community cohort that responded to our advertisements. Like I said, there was benefit seen for fear of falling and gait speed, which has been associated with falls. So I guess we have seen that the high level of acceptability suggests that it is possible to teach people 65 and over to undertake a home-based exercise program in a group setting. And we could look at, I guess, enhancing this model to produce a greater challenge to balance, behaviour change strategies to promote adherence, and targeting those who would benefit most from an exercise program. So I guess we can see that one size doesn't fit all, and exercise programs that are delivered in a variety of ways, whether that be home-based, group-based, individual, need to be offered in the community to allow people to reach that level of exercise that's required for preventing falls. So next steps, I guess looking at using this just as an introduction to exercise rather than a long 12-month program, with the aim of progressing participants into more challenging exercise programs, and look at targeting specific groups that could really benefit from this type of program, such as more frail, people who are at home in caring roles and are unable to leave the home. And we're currently looking at a small pilot with people with chronic health conditions such as COPD in our virtual care centre, which has presented some other challenges in itself in a sort of very real world setting. And we look forward to sharing those results with you down the track. Just like to acknowledge funding from the NHMRC and our research team. Thank you. Any questions? Yes. We did, yes. So, yeah, we did the memory impairment screen when we talked to them over the phone. So they were excluded if they had cognitive impairment, yes.
Was there any additional contact with the participants outside of the 1, 4 and...
We did, we had assessments at baseline 3 months and also at 6 months. So they came back at 6 months for physical assessments, but they weren't given exercise instruction at those sessions, but we were in touch with them at that point. Yep. Thank you.